We are live.
Okay, we are live. Thank you. Sorry, I wasn't working before. And this morning we have in with us the Vermont Cancer Initiative, and on screen, Dr. Page is with us. So welcome.
Thank you. Thank you so much, Chair Black and members of the House Committee on Healthcare. I appreciate the opportunity for Dr. Holcomb and me to join you. As you may hear my voice, I've got an upper respiratory infection of some sort. I didn't want to expose you to it, so I appreciate the opportunity to have a Zoom link.
Yep.
By way of introduction.
Let's let Dr. Holcomb come up. I'm sorry, I didn't see him sitting over on the side.
You bet. Hi, Randy. By way of introduction, I have met many of you already. I am a clinical cardiac electrophysiologist. That's a heart rhythm specialist. I actually still see patients Tuesday mornings. And since 2018, I've had the great privilege and honor of serving as the Dean of the Larner College of Medicine at the University of Vermont. I came here to make a difference for our college, UVM, and our state. And soon after arrival, I recognized the need for the Cancer Center at Vermont to be designated by the National Cancer Institute, or what we'll be referring to as NCI designation. The designation isn't what matters. What matters really is the excellence that this represents and the opportunities that it offers. University of Vermont, and Vermont had a cancer center until 2008. And unfortunately, there was not ongoing support from the university and the college and the hospital to maintain that, and cancer center designation was lost at that time. And ever since that time, there was an aspiration, but really no success in getting closer to getting NCI designation back. So when I arrived, as I mentioned, I saw the need, and my experience having served in North Carolina at Duke, at UT Southwestern in Dallas, at the University of Washington in Seattle, and most recently at the University of Wisconsin, I saw what an important entity a cancer center is to a state and region. So I invested a significant portion of the resources that I have, which are limited, but substantial amounts to getting us going to this journey. And with the partnership of Steve Leffler, John Brumstead, and then Provost Patty Prelock, we agreed that this was something that we should bring back to the state. We installed interim leadership and conducted a national search, which culminated in recruitment of Dr. Randy Holcomb, where he had been the designated cancer center director at the University of Hawaii. Since that time, the progress has been nothing short of spectacular. Even the External Advisory Board, which met just in November, described, quote, the tremendous progress that they've seen at their annual review. One factor that's still missing, though, as noted by them, and fundamentally in the world of obtaining cancer center designation, is state support. We need to demonstrate that the support is serious and in order for us to receive designation. I should note that substantial support from other states is based on good business as well as good healthcare. An NCI designated cancer center is a driver of the economy. It supports good jobs and brings substantial economic benefit to the state where it's housed. Today, you're going to hear from Dr. Holcomb about some of the specifics and the amazing progress he's had in terms of the cancer center development, its impact on education, research, community outreach, and most important, clinical care. But to get there, we need your help. My final note before turning things over to Dr. Holcomb is that cancer center designation will have a positive impact on every resident in the state who might be at risk of or have cancer. And finally, as you consider our proposal, I'd like to emphasize that cancer center designation will have a positive impact likewise on every doctor, including every primary care doctor in all 14 counties. To have this resource, to have this direct line for cancer care, advice, education, as well as support for the patients they're caring for, I believe will enhance every physician's job satisfaction, and if anything, will help us recruit and retain the statewide healthcare workforce. So with that, I hope there'll be opportunity for questions. I really appreciate the opportunity to open things up, and I'll turn things over to Dr. Holcomb. Thank you.
Thank you.
Chair Black and members of the committee, thank you very much for inviting me to speak to you today. It's always hard to follow an introduction from Dean Page. That was a very nice introduction, Rick. Thank you. I thought I would remind you just a little bit about who I am and my journey, in case you don't remember from last year while I was here, and then just highlight a few points about some of the really exciting advances that we've had over the last year, and then talk about a proposal of some of the things that we'd really love to do moving forward. So I trained, I'm a medical oncologist. I practice medical oncology 2 days a week. I'm also a researcher. I trained at Brigham and Women's Hospital in Boston. Went to a few different places. Most recently, I ran the clinical oncology program for the Mount Sinai Health Network in New York City, before moving to Hawaii and being director of the NCI designated University of Hawaii Cancer Center. And I've been at the University of Vermont for the last 3.5 years. My mission in coming here was to really build the center and achieve excellence in all of our 4 pillars, which I'm going to touch on in just a moment. And that we would build the center in such a way that we would be able to attain NCI designation, really as an affirmation of the growth that we've done, and the excellence in all of the critical areas in supporting cancer research, education, community outreach, and clinical care. This is attaining NCI designation is not only an affirmation that we're doing well, but also an opportunity for the state. I've been in NCI designated cancer centers for the last 25 years of my career. I know what kind of impact that has on reducing the burden of cancer for the people of the state, as well as what is felt to be a 2.5 multiplier factor for economic impact for every extramural grant dollar that's brought in by the Cancer Center. And for us, since we bring in $20 to $25 million in extramural grants each year, that has a potential impact, economic impact of about $60 million for the state of Vermont. Our Cancer Center is really focused on or centered on 4 pillars: research, education, community outreach, and clinical care. Just to highlight a few things that have happened over the last year, we have some research programs that are specifically focused on melanoma. Vermont happens to have the 2nd highest rate of melanoma across all the states in the United States. The reasons for that are not completely clear, and we're doing research to understand how UV radiation actually modulates cells and causes them to become melanoma cells. And so that we've had some great publications over this past year, which have made some great advances there. We've also recruited some new faculty in really exciting areas. One new faculty member studies the microbiome, the gut microbiome, the bacteria in the gut, and how that influences how cancer grows in patients, and also how patients can respond to the newer immunotherapies by modulating the microbiome. Again, very exciting things. And then another new recruit who is focused on engineering bacteria that would be present in probiotics that are non-pathogenic, so that they can detect cancer cells, to potentially utilize these bacteria as a new mechanism for cancer detection. And the reason that we're so excited about that is because this is potentially a way that we can increase screening for various cancers, including lung cancer, in our rural counties in the state where our screening rates are actually very low. Education is our 2nd pillar. We've had some great things happening this year. We continued our Careers in Cancer event, which supports high school students to come to the laboratories at the Cancer Center to see what really high-level science is, and get them excited about future careers in STEM fields. You'll see that in the proposal of what we do what we'd like to do moving forward is to really bring that sort of experience out to all the counties across Vermont, and not just have that localized in the Burlington area. We also are sponsoring our first Rural Health and Cancer Conference. It's a national conference, which is going to be held in June. We have continued to offer research experiences for high school students, undergraduates, graduate students, and medical students in our Cancer Center laboratories. One advance or two advances that I'd like to point out on our community outreach have been focused on cancer screening. One of them has been a partnership we've had with the Vermont Language Project to translate breast cancer screening information into Nepalese and to increase the mammography screening rates for Nepalese women in our state. Another is what we're very proud of in a big effort to try to increase lung cancer screening. Lung cancer rates in Vermont are not higher than the national average, but they're much higher in our rural counties than they are in Chittenden County. And part of that has to do with cigarette smoking. Part of it has to do with the lack of access to screening, which requires low-dose CT scans. We have had a big initiative over the last 2 years to increase lung cancer screening rates, and we've increased them by 33% in the state of Vermont. So we're very proud about that. And then lastly, from a clinical care point of view, we continue to explore how to use the new immunotherapies to improve survival, which has improved survival for patients here in Vermont. We offer clinical trials. We have an exciting clinical trial for colon cancer, which allows us to help to decide by using circulating tumor DNA testing to see if patients actually need chemotherapy after surgery or whether they need even more intensive chemotherapy than the standard chemotherapy. So this is a very exciting protocol as well. And a lot of our clinical trials focus on decreasing the frequency of treatments and decreasing the toxicities of treatments, because we do have lots of patients from rural counties who travel to our center to receive care, and it's much more difficult for them to come on a repeated basis if we can have them come less frequently but maintain the efficacy of those treatments. So that's just a little summary sort of in our 4 pillars. And I wanted to touch on a few things of what we'd really like to do moving forward, if we can, with the support of the legislature. And I have hard copies of those things too. If anybody would like them, I can pass the whole stack around. You can pass those around. So we have 4 programs, some of which we've actually started, and some of which we'd like to expand. One is our rural oncology training program by training hematology oncology fellows in rural healthcare delivery. We know that most physicians, after they finish their fellowship training, stay in the area where they did their fellowship training. And our feeling is if we don't train our oncologists how to treat people in rural areas, they will not practice in rural areas in our state. So we have already started this process. We've gotten approval from the American College of Graduate Medical Education to expand our fellowship program. We are starting in July to expand that program. But we need some support to make sure that we can get these fellows the appropriate public health training, the appropriate training in rural healthcare delivery, and also to send them on rotations to rural sites across the state so that they can really learn about the benefits of practicing in a rural community. A second is our mobile lab on wheels. This really recapitulates what we're doing with our Careers in Cancer event in Chittenden County by bringing exciting science to rural high school students across the state. And on the other page there, you'll see a map of where our initial schools that we've already have commitments from to bring this to, and where we'd like to bring it to moving forward. We've already invested about $100,000 to $150,000 in this project. We've already obtained a van. We've outfitted with microscopes, fluorescent microscopes, and screens so that people can see what's going on, and little experiments that can be done that are more intensive and exciting than what they may see in their normal high school curriculum. This project also is in partnership with the Department of Education and is not just aimed at the students, but also at the teachers. to help to teach them about different ways to modulate their curriculum to really make it exciting for students. Because I think that if we get more students, especially those from our rural counties who are interested in STEM careers, we're going to bring back people to our area with really good skills for very good jobs. We'd also like to expand our support of primary care providers across the state. We have a shortage of doctors in almost all specialties and subspecialties in Vermont. Primary care providers are under lots of stress. Generally, they don't like to see patients who have cancer because they don't feel comfortable in treating them. And so very often patients, even our patients from rural counties, are told by their primary care provider that they really can't be helped there. They have to go to their oncologist who might be in Burlington, or they might have to travel for some distance to get there, really for routine healthcare. What we'd like to do is establish the infrastructure so that we provide support for those primary care providers so that they have a number to call. They can call a nurse practitioner who works under one of our oncologists who can help to answer questions and have care for hypertension and diabetes and such really managed close to home. And we think that that will benefit our patients across the state. And finally, we have done a survey to see how many dietitians are supporting ambulatory cancer patients across the state. It was 2.4 dietitians. And that's not enough dietitians to support 5,000 new cancer cases a year in the state of Vermont. And so we have started to provide nutritional consultative support on a remote platform. We've started this now with Bennington at Southwest Vermont Medical Center, which is not part of the UVM Health Network, but part of the Cancer Center's area of responsibility because we focus on the entire state. And we are now starting to provide nutritional patients, new patients who are presenting there and starting on cancer therapy in the hopes that that will actually improve their quality of life and improve their tolerability to cancer treatment. So these are some of the programs that we'd love to move forward. We've already started some of them, but continuing them will, of course, take some resources. And I hope that we can continue them because I think they'll really benefit patients across the state of Vermont.
All right. Thank you both. Have you felt any of the impact from the new federal administration and that's to the National Institute of Health as far as your research goes?
So I would say not so much yet, but we're of course very concerned about that. We have had a few awards, just a very few that have not been reissued, but for the most part, our grants are currently intact. We do have lots of individuals who are working on healthcare and especially in the area of cancer disparities in at-risk populations, looking at the factors that contribute to those disparities. We're a bit worried about some of those projects moving forward, but as of yet, we haven't seen any cuts, but we're vigilantly watching the landscape there.
Thank you. Brian.
So I always find these presentations really interesting in terms of the science. So I'm going to try to not start asking too many questions. Maybe we could talk later, but I'm curious about, so on this form, it says $1 million a year investment. So I'm curious, like when you said that state support would help secure designation, I don't know if you said it exactly that way. Is there a dollar amount, that threshold we have to meet to secure the designation? Like this $1 million ask, is the rule like if a state doesn't give at least $1 million of its state budget, you can't get designation? Or can the state of Vermont put $1 in the state budget and you get designation? You know what I mean? Like, is there? Yeah.
So I doubt a dollar would carry much weight. Just to add that. So just as an example, at the University of Hawaii Cancer Center, the state put $20 million a year into the Cancer Center.
Do you know what the state budget is of Hawaii, though?
Actually, Hawaii's not a real rich state, to tell you the honest truth, so it's relatively comparable. Now, I did pay, they built a new building for the cancer center, and I did pay about $15 million for the bonds for that building. So the sort of discretionary funds to do projects and research and improve clinical care was really about $5 million a year there. I know Oklahoma, which has a much bigger budget, puts in about $20 million a year. Gainesville, Florida obviously has a much huger budget, puts in about $20 million a year. I don't think there's an expectation that Vermont would come close to that because we're a small state and we're a relatively small cancer center. And I think that some significant support that helps to support programs that we can show that there's impact of those programs on our community and reducing the burden of cancer. I think that's what's critically important, more so than the number itself.
Okay.
So I didn't answer your question and give you a number.
If
I don't
I-
think I can.
You kind of did, although it sounds like
Yeah. If I-
Paige wants to say something.
Yeah, if I might chime in. When I first got here, we did a reverse site visit with the National Cancer Institute. And they started throwing numbers like Oklahoma just got designated and they were committed $20 million a year. And I said, if you expect that of us, I'm going to spend my money elsewhere because the state of Vermont can't invest to that level. And they backed away and they recognize that, that we're a smaller state and a smaller budget. You may recall last year we requested $5 million and per year for 5 years is kind of to get things moving. And we were pleased that $1 million was, I think, made it out of one committee, but never made the governor's budget. $1 million is what we are asking for, and it as Dr. Holcomb mentioned, it's really twofold. One is it will make a difference in what we can do for the state of Vermont, and we are in competition with other states, and the NCI is looking to leverage its investment. And if a state is not contributing, they don't believe there will be an ongoing relationship and commitment, and they will spend their money elsewhere and designate another state's cancer center. So from our standpoint, we are very much hoping that $1 million would be the number, recognizing that's relatively low compared to other states with much bigger budgets, obviously. But any commitment from the state would be seen as a positive development and potentially help our application in the fall of 26.
Yeah, keep going.
Yeah, all I want to say is I generally support what you're doing, and that's why I asked what the minimum amount is we could give to get that designation. And my only concern is nothing to do with you all. It has to do with the financing of the hospital system and the amount the CEOs get and stuff that people at the top are getting, and that's like one person's salary in some positions. But if there was a way we could move money around within the system or find that $1 million, I would support it because the work you're doing is fascinating and interesting. And I have so many more questions about it that I'm not going to ask now because, but every time you talk about it, I get excited and want to hear more.
And Brandy, you may have the numbers there, but in excess of what we're requesting from the state is already being invested by the health network and the medical center in the cancer center. And way in excess of that is coming from the state, University of Vermont, Larner College of Medicine, from my budget. So of the partners of state, hospital, and academic center, this would be a smaller but really important contribution than either of the other partners.
Leslie, did you have a question? And then I think Laurie and Todd.
Thank you. Thank you.
I mean, Daisy.
Sorry, is it my turn?
Yes, it's your turn.
Okay. I think last year we talked about palliative care, hospice care, and what your center was doing in that part of the cancer world. And my memory, and correct me, was you're obviously research focused. I get that. And I also get that there's a disconnect between treating cancer and palliative care. And I think we're sort of negotiating that in our new AHEAD model that hopefully we sort of get rid of that problem so that people can be on hospice and still be treated for cancer. So that would be a good thing. So I'm just wondering if your center is thinking about how in rural areas to expand palliative care working with primary care and hospice care, that kind of thing?
Yeah, so we work very closely with hospice care all the time, of course. And that's of course spread across the state. I would say that there's not a disconnect between palliative care and active cancer care. Hospice care, obviously, we cannot do active cancer care on hospice. Those are the regulations. But we actually have an ambulatory palliative care program at the cancer center, as well as an inpatient palliative care program. We co-manage our patients between the palliative care physicians and the oncologists because we feel that in many cases improves patients' quality of life and often symptom management and things like that. So I think I'm a very big proponent of palliative care. Obviously, we can't do everything. I had that in our sheet. I think last year we asked for a little bit more money last year. Obviously, we would love to extend the same sort of activities that we would like to do with nutrition for active cancer patients, with palliative care, provide an infrastructure where we can provide that sort of backup that is needed for rural areas, so that we can have palliative care practitioners go out to see patients close to home rather than having patients having to come into a center. And I think that would be a great idea. I think we're just looking at how much funding we might have to be able to do that. That'll obviously take some resources as well. But I think it's a great thing we'd like to do, and maybe something on next year's agenda.
That would be great. Do you have any data, if I may just follow, on when patients from your centers are referred to hospice before death?
So I don't have that data specifically, but I do know that our rate of referral within the last month of life is very low, which means that we are referring patients before that.
That's ideal.
Yes.
And of course, we know there's a problem there with referral, sometimes a week before.
Yes, that doesn't help.
It doesn't-
So that doesn't help. We do have some patients who are referred, very soon before death. Usually those are patients who've been hospitalized or in the
maybe
hospital
declined, and I
and things
get
like that.
Yeah.
But for the bulk of our patients that are solid tumor patients, we have those discussions on an ongoing basis. And part of that is because we partner very closely with the palliative care group throughout their treatment.
Is that one of your quality measures?
One of our measures is the time of enrollment at the hospice compared to the time of death. Yes.
Thank you.
Daisy?
Thank you for coming to see us again.
Yeah.
For something as difficult as cancer, we need to have a long-range strategy, I think, for consistently supporting the research. And I'm wondering, being a part-time legislature with no staff, sometimes it can be difficult to be strategic in our approach to budgeting. Have you approached the governor to be included in his budget?
So I'll have to defer that over to Wendy, because I don't personally go and approach the governor about things, but Wendy can answer.
I'm the executive director of government relations at UVM, and the answer is yes. Both last year and this year, we met with the governor in the fall, made this request as one of our part ask. We asked for a 3% increase in our general fund appropriation, which he included in his budget, but we had two one-time asks. The ask for the Vermont Cancer Initiative, and we also asked for some support for our Vermont Tech Hub, and neither of those one times were included in his budget.
Just with the 3% was for what?
Excuse me?
What was the 3% for?
It's for our general fund appropriation. It's an increase.
For the cancer center?
No, for the university.
Oh, the
of
whole
Vermont.
university, got it. Thank you. Robert?
Do you know if the state of Wyoming has one of these cancer centers?
I don't believe Wyoming does. I believe that Wyoming falls in the what we call a catchment area, the area, our service area. Every cancer center has to define that. I believe they fall within the catchment area of the Huntsman Cancer Institute in Salt Lake City. So there are several states without cancer centers, little little uncolored spots along the map. Vermont is one of those at the moment. I believe Wyoming, Montana, mostly rural states, appear on that map.
I'm just wondering if they did what they were getting.
Yes, I don't think they have one. And I don't even think that they are aspiring to provide that kind of service from an institution within their state for their people.
Thank you.
Any other questions? Woody?
What surrounding states like Hampshire, Maine, Massachusetts, what surrounding states have a cancer institute?
So Dartmouth is an NCI designated comprehensive cancer center. I think they've been 50 years NCI designated. Obviously a lot of people along the sort of eastern border of Vermont go and get their care at Dartmouth, which is great. We actually collaborate with Dartmouth a lot on lots of different projects. For instance, our Sun Safety campaign, which brought sunscreen dispensers out to public parks across Vermont, was co-sponsored with the Vermont Department of Health, our cancer center, and also Dartmouth Cancer Center. So we do work closely with Dartmouth, though obviously they don't see the bulk of the patients in Vermont from Vermont. Maine does not have an NCI designated cancer center. The closest one going west in New York would be out at Rochester. And Massachusetts has, I believe, 2 NCI designated cancer centers, Dana-Farber / Harvard Medical Center. And I believe the Boston University may have a NCI designated cancer center as well. So they'd be the closest ones.
Oh, thank you so much for coming in.
Well, thank you
Good to see you again this year.
Thank you for giving me the opportunity. It's always a pleasure to come here and talk about the Cancer Center, and I really appreciate the opportunity.
Thank you for the remarkable work too.
I have one last question. I'm sorry.
No, go on.
I have, and I may have missed it, but is it possible that the Health Network would make a contribution to this? Or have you?
So the Health Network does. The Health Network puts in, as Dean Page said, more than that $1 million a year to support the Cancer Center. So that comes out of their budget, that they have some discretionary funds to help support that. Most of that support goes really toward 2 things, which are crucial, I think, for our patients here in Vermont. One is to support our clinical trials infrastructure so that we can bring novel therapies to patients, especially for individuals who have diseases that we don't treat very well. As you know, like, for instance, pancreatic cancer that we don't treat very well, that we really need to have develop new therapies, and also to help support investigators to be able to conduct those clinical trials. So those are some of the things that we utilize medical center resources for, but they do provide some funding every year.
Given the profits that UVMMC had in their budget this year, have you considered asking them to cover the costs that the governor didn't cover in his budget ask that you made?
I'm always asking the medical center for more funding, quite honestly. So that's not something I'm shy about.
And they have access, we don't.
Well, they feel that they're giving what they can give at this time under the pressure that they feel that they're under from various regulatory bodies. And so I'm appreciative of the support that they give. A lot of the things that are in this proposal, are really focused on the state of Vermont outside of the Health Network. The Cancer Center is not limited by the confines of the UVM Health Network. And so we really feel that we have a much broader mission, and that we need to serve people from across the state. And of course, that's not where the UVM Health Network is. So these are really sort of potentially different funding streams to support different initiatives that the Cancer Center is focused on.
Thank you.
All right.
And if I may just close and thank everyone and mention one thing. I've visited with you all intermittently since 2018. We didn't immediately come to the state for support. I garnered support from the health network, the hospital, the university, and put in significant funds here. And we are on track for fall of 26 to have a submission. And ideally, when we submit in 26 to have the credibility and the potential to be designated, we're at the point now where if we don't bring in state support, that will hurt our ability to bring this resource to every patient and resident in Vermont and to bring in the economic benefit. So as opposed to last year, the good news is we're 1 year closer to that date that Randy and I have been talking about for 3.5 years, and I've been looking forward to for 6. We're really getting close. And for that reason, as opposed to last year, where we're actually cutting back our request, we're asking for people to see the increased urgency, because fall of 25 is coming up and fall of 26 is when we're going to be submitting. So thank you for your consideration. It's an honor to visit with you today.
Thank you. Oh, Woody, did you have one real quick question?
I do. How difficult is it to get an appointment? You know, if one discovers they have cancer, what's the waiting list to get in to be seen?
So the waiting list is always, you have to understand where things start, because someone might wait 7 months for a colonoscopy. They might find that they have cancer, and then they say it took 7 months to get in, for treatment of the cancer. When we know a patient has been diagnosed with cancer, they are seen in our practice in less than 2 weeks.
Thank you.
So we always, cancer is an urgent issue, and none of us feel that it can be delayed. What we try to do is we have implemented, through the support of the medical center, what we call an upfront navigation program, so that if patients are diagnosed with cancer and we know they're going to need a chest CAT scan, for example, instead of just having an appointment with a doctor and the doctor says, "Oh, well, you have cancer, I'm going to have to schedule a CAT scan for you and come back, next week or the following week." We will have the nurse navigator work with the patient, get all of the testing schedule that's needed, so that when they actually have the appointment with the physician, which will be within 2 weeks anyway, all of the information that is needed to make treatment decisions is already available. And so that's what our commitment is. And we do not have an access issue for patients who are diagnosed with cancer.
That's very good. Thank you.
Thank you. Thank you both.
Thank you again.
Thank you. Have a good day.
So we're turning back to H266, which we started taking testimony on yesterday. And we're going to start with Jordan Esty from MVP. Welcome, Jordan.
Good morning. Can everyone hear me all right?
Yeah.
Great. So thank you again for the opportunity to testify on H266. For the record, my name is Jordan Esty. I'm here representing MVP Healthcare. By way of background, we're a regional community-based not-for-profit health plan serving upstate New York and Vermont, and we have about 33,000 members in Vermont's fully insured commercial markets. So I want to spend just a minute or two providing some context around this issue, different dynamics, to help the committee understand the payer's perspective. I'd ask you all to take the journey with me for a minute, because we're all ratepayers here. So, put on your ratepayer hat, to put my comments in perspective. So, as I mentioned, MVP is a community-based plan. We have deep relationships with a lot of the federally qualified health centers and safety net providers throughout our community. Outside of my professional role with MVP, I sit on the board of a rural federally qualified health center serving Northern New York. So both MVP and me, certainly in my board work, fully understand the importance of the 340B program and how critical it is for, really what are the bedrock of our local healthcare system serving the most vulnerable among our community. I would urge the committee to separate the 340B program from issues of healthcare reimbursement, health insurance reimbursement, because, in my opinion, I think it muddies the water a little bit. And as I'll get into, I think there's unintended consequences that we want to be mindful of in terms of cost and some things that are happening, in the markets today. So I know this was covered yesterday, but the 340B program, really it's a federal program that, as a condition of participating in Medicaid, drug manufacturers have agreed to provide discounts on drugs to these designated, critical community providers. So importantly, as payers, we're not involved in the 340B program. This is a manufacturer and a provider program. We pay for medical services, including prescription drugs that are delivered by these providers. And this is a really important distinction because we only know what we pay for. We don't know, for example, if the provider acquired that drug as a 340B drug as part of their participation in the program or some other rate. So as a payer, we're simply paying the bills that we receive. Now, an important distinction here is how different providers are reimbursed. So a federally qualified health center, an independent physician practice, tends to be paid on a standard fee schedule. So for prescription drugs, we generally have a sense of what that price is, and we're paying generally based on the average sales price of a drug in the market. So let's say a drug is $100 average sales price. We know that's what we're paying generally around that amount, and that's kind of the market standard for the drug. If that provider happens to be a 340B provider, they've acquired that drug at a discount. Let's say it's a 50% discount, so they're paying $50 in this example, and we're reimbursing them $100. That margin is the amount that the provider, the 340B provider, gets to reinvest into the services they're providing to the community as the public good, the public benefit. But again, as the payer, we know kind of generally what the price is, and we're paying that price regardless of whether it's a 340B drug or not. Now, hospital-owned clinics, outpatient clinics, are generally not reimbursed under a standard fee schedule. They often tend to be reimbursed as a percentage of their total charges. And there's many reasons why they're paid differently. But notably, they're part of a larger system. There's lots of overhead and other costs that are being supported as part of their cost structure. So for prescription drugs in these outpatient settings, this means we're paying a percentage essentially of what they're charging for their services. So very different than a fee schedule. It's a discount off of what they're charging for the service. So that's an important distinction between FQHCs and independent practices and how hospital-owned outpatient clinics are typically paid. And this is a national trend. It's not one we're seeing only in Vermont, but we are seeing it in Vermont as well, that drug prices and drug costs, when provided through hospital-owned outpatient clinics, we're seeing significant cost trends. So I think Blue Cross Blue Shield yesterday had provided some examples of significant markups on the drugs relative to what we're paying throughout the rest of the market, which is driving higher drug costs, higher costs for ratepayers in the forms of premiums and out-of-pocket costs. And I would just note that there's a lot of research, there's a lot of discussion and healthcare policy debate happening nationally right now about this dynamic, and the real challenge and the trend that we're seeing in outpatient drug costs generally. So with that is background, I'll pivot specifically to H.266. I think we have significant concerns with the insurer reimbursement provisions of the bill. I think first, importantly, we're already prohibited from requesting any information on a claim or with a service that's provided that would permit us or a PBM from knowing if the drug that's covered that we're paying for is a 340B drug. We have no insight to that information. So, where this is a concern, what's proposed in H.266 is at best, much of these requirements seem redundant and unnecessary as they relate to health insurers. I would note that we have, I think, significant concerns with the violation standards with this in mind, which establish a right of action for providers to sue us as a payer for perceived interference with their 340B programs. When again, we don't know when they've acquired a drug under the 340B program or not. We simply know what we're being billed or what we're being paid. So that, that lawsuit authority, in my opinion, seems inappropriate, misaligned with what the current law already requires of us, and the fact that we're not collecting this information today to really understand if it's a 340B drug, and therefore if we we were to, the interference language in the bill to me reads as very broad, and I think raises various questions. So if MVP were to design a benefit or a cost share or some site of service program that provides members with information on costs in hospital outpatient settings versus other settings, would we then be interfering with a provider's 340B program under this bill, and would we be subject to potential legal activity as a result? simply for, in our view, doing what we can to help our members find affordable options and understand what their drug costs might be. I think the appropriate policy balance here, given how sensitive we all are to healthcare costs and affordability, in Vermont right now, is to focus on the 340B program, and that is really the dynamic between the manufacturers and the 340B providers. So if the manufacturers are taking steps that are limiting, the discounts they're providing to these providers under the program, I think that's, an appropriate, it's an appropriate area to focus as a public policy matter. There could be a general fairness, a provider protection dynamic that's important to consider there. But, to balance the very real affordability issues we're seeing, again, in hospital outpatient settings, I would urge the committee to strike the insure and reimbursement sections from the bill. Again, this is a challenge nationally, and again, we're seeing it in Vermont. I think it warrants, from a policy perspective, a real study of these cost issues, the trends that are happening related to this type of drug coverage and where the drug is provided, to understand that at a deeper level before we lock in any language or requirements that has unintended consequences for ratepayers. So I would point out that the transparency requirements in H206, for example, I've taken a look at that bill, would go a long way in advancing this conversation. Short of that, this is an issue that the Green Mountain Care Board could study to help really inform the policy discussion and any necessary actions. When I spoke to the committee last month, I had urged you all to be very cautious of changes that unequal the playing field between state-regulated insurance markets and non-regulated markets. And I think this is a good example of that type of dynamic where I noted earlier, under existing state law, those of us that are regulated by state laws participate in those markets. So MVP, Blue Cross, Cigna, we don't have access to this information today. We don't know when a 340B drug is used, and we can't seek that information. So to the extent that any payer or PBM is doing that in the market and is placing restrictions on providers that are challenging, their ability to operate the program, it's not, to my knowledge, happening for many of us. So to further extend these requirements and create unintended consequences only on the state regulated markets is not going to solve any issues that may be happening among payers that sit outside of the state regulated markets. A very complicated issue. Appreciate the opportunity to join this morning and talk about this, but happy to answer any questions. But again, just to reiterate, our perspective, our concern is that we would urge you to strike the insurance and reimbursement provisions and focus on the 340B elements between the manufacturers and the providers. And this is not a unique idea for me. I did see a similar bill introduced in New York last month that is narrowed and focused on the manufacturers and any interference they may be engaging in. So there is precedent in other states in terms of how other states are looking at this.
Thank you. And can you send us your asks in
Yes.
writing, summarized in writing? I didn't see anything that we'd gotten. Any questions for Jordan?
Your background is cool.
Yeah, you do have a new background, I've noticed.
Good color scheme.
Okay, well, thank you so much for joining us.
Thank you for having me. Take care.
Next we have Jonathan Reynolds from Rutland. Oh, I'm trying to think, did we see you on the screen or?
You saw me on the screen last time,
Okay.
a week or two ago, but this is important, so here I am in person. CONs, yes, page 96.
Thanks for joining us.
Yeah, absolutely. So good morning, everybody. Thank you for allowing me to provide testimony here this morning. My name is Jonathan Reynolds. I'm Vice President Clinical Ops at Rutland Regional. I'm a pharmacist by training. I've been at the hospital for 17 years. I'm fortunate to serve on the Vermont Board of Pharmacy, and I have been closely involved and very involved with our 340B program at Rutland Regional since we became eligible in 2011 as a result of the 2010 Affordable Care Act. So thanks again for having me this morning. So we'll start by saying that at Rutland Regional, we agree that healthcare costs are unaffordable, and we know that we have a responsibility to be a part of figuring out ways to make it more affordable. With that said, we feel that 340B, and specifically the contract pharmacy discussion that we're having, is a vehicle for us as a hospital to specifically decrease those healthcare costs. So as Devin mentioned yesterday, in the spring, summer of 2023, while we were preparing to submit our budget to our commercial rate increase budget to the Green Mountain Care Board, that was the time when manufacturers started to restrict access. We said, we're losing a lot of money very quickly. And that is where we took the intentional step to increase our rate request by 2%. So that was a 2% increase simply because of this lack of 340B revenue that was eroding. It was drastic and sudden. So really what I'm trying to say is that because of the drug manufacturers' decisions to limit this 340B contract pharmacy access based on their own interpretation of what the rule says, themselves alone, they shifted the costs from themselves onto the back of Vermonters. And you can see that as we increased our commercial rate increase request. So I'll go into a little more detail of what this program means to us. So at Rutland Regional, the drug manufacturer restrictions have resulted in a loss of $8 to $9 million a year. These dollars are vital to us because they help support the underfunding of Medicare and Medicaid programs. We quantify that as about $39 million a year of it costs more to provide that care than we're funded. 340B helps offset that delta. Speaking more broadly, around 70% in fiscal year 24, 70% of hospital operating margins can be specifically tied back to 340B. So I really just want to convey the point that 340B from a margin standpoint for Vermont hospitals is incredibly important. As Medicaid cuts are looming at the federal government, this becomes even more important that this funding source is restored. These dollars are vital, and I'll go into why in a second. Essentially, as I mentioned, this helps fund programs that are loss leaders for us. And so programs like our labor and delivery unit, our behavioral health programs on the inpatient and outpatient side, our palliative care program on the inpatient side. These are all programs that, as funding such as the 340B program, if that dries up, we have to make those tough decisions on what can we afford and what can't, what can we continue and what can't we. I will read a bit here that the 340B federal statute that this law is based in states that the intent of the program is to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. Period. Doesn't say anything else. It doesn't say that covered entities need to pass on discounts to insurers or pass the savings directly on to patients. Now, I'll say why that's important, because at Rutland Regional, we also use, in addition to supporting these funds for these loss leader programs, we use these 340B dollars to support our financial assistance program, which goes up to 500% of the federal poverty level, so that hits not only medications, but also hospital-based services, clinic services, things like that. So it's a broader approach that we use those funds for. I'm just shuffling through my notes here, I'm sorry. Additionally, at Rutland Regional, we provide medications to local EMS ambulance services. Some are located just outside the hospital, but also part of local town municipality volunteer ambulance services. Again, it's a question of how far do these 340B cuts go? And if we have to make hard choices, those costs of those drugs that we provide to these ambulance services may need to be pushed back to town municipalities in their budgets based on essentially what can we afford to do as 340B access continues to decline. So I'll shift and say that RMC is willing to provide increased transparency to the 340B program as long as the requirements are reasonable. So as presented, we have some concerns with some of the language. I'm happy to go into more detail, but provisions aimed at notifying patients when they've been given a 340B drug is just going to lead to confusion. As you've seen in the past 24 hours, this is not a black and white program. This is a gray program. And a patient just receiving a letter in the mail saying they got a 340B drug, that's going to lead to all sorts of questions, confusions. We're going to have to open a call center just to answer these. So it's just something we would push back on. So just flipping through my notes here. I will move into to say that I also need to clarify that a lot of the presentations a few of the presentations or the testimony that's been provided also confuses or blends the two aspects of the 340B program. And without going into a lot of detail, there are two aspects of the program. One is what we refer to as mixed use. These are the medications that are dispensed from a hospital pharmacy to its outpatients in its clinics, in its infusion centers, cancer centers, things like that. Think of the hospital pharmacy, the clean room, medications being delivered from that. That is medications from a mixed use 340B standpoint are provided. Those are billed to medical benefit. That's a medical insurance benefit. What we are here and seeking relief from is the 340B contract pharmacy restrictions that manufacturers have put on that. So when I say contract pharmacy, those are the medications that you go and you bring a prescription to any CVS, Walgreens, independent pharmacy and get a prescription and you take home and you self-administer yourself. So really what I'm trying to say is often those are just the oral tablets. Sometimes they are injectables, but these medications are essentially those ones you go to prescription and get filled and provide at home. So I want to clarify that H.266, what as a hospital we're requesting relief from is that contract pharmacy piece. And yesterday and this morning, you heard reference to specific meds that were discussed, infusion meds such as Inflectra, Kanjinti, Neulasta, Remicade, Ruxantz. Overall, those medications are infusion meds. Those are not medications that you're going to go to CVS and Walgreens and get. So while there is a cost discussion that we have to associate that it can be discussed there, I do just want to clarify that the piece we're seeking relief from is the manufacturer restrictions as it relates to contract pharmacy so that we can work with these programs and resume the revenue that supports the programs I mentioned. So I just want to clarify that I'll summarize by saying that a lot of the information that was presented yesterday and to an extent this morning is not necessarily aimed at the fix that we're trying to accomplish here with this bill. Happy to answer more questions on that. Lastly, I'll say that if you bring a prescription to any of these outpatient pharmacies, Walgreens, CVS, and independent, it's the pharmacy benefit manager that dictates what the price is. It's not the covered entity that writes the script to then give you to a patient to then go and get filled. So there's no added cost that the hospital or an FQHC is adding onto that because it's determined by the pharmacy benefit manager. So I will conclude by saying that just to remind the committee that over half the states in the United States, red and blue, are looking at this legislation. This is not just a Vermont thing because of the strain the manufacturers have put on us. Not only does contract pharmacy and 340B support hospitals and FQHCs, but it helps shift the cost burden off of the backs of Vermonters and restores the program with drug manufacturers. And I just want to say that we feel like we can't wait any longer. Ongoing studies into data dives is only going to compound the problem because we're not receiving this funding now. And as additional manufacturers continue to restrict the access, the situation is just going to get worse. So I'll close by saying at Rutland Regional, we can confidentially say that if this contract pharmacy provision was restored and the funding source was resurrected, it would have certainly a positive impact in allowing Rutland Regional to reduce the commercial rate requests going forward. So those are really what I'd just like to say in support of H.266. I will happy to answer any questions that you may have. I know I got into some deeper details there, which maybe created some confusion, but happy to clarify those as needed.
Leslie? Well, a lot of it did.
Sure, yeah.
But I'm wondering if you could give us a hard copy with a summary. So, because what we're going to have to do is as we go through the bill, be able to go back.
Absolutely.
And review.
Yeah,
So I
absolutely.
appreciate that.
Happy to provide that information. Yep.
Thank you.
Any questions?
Great.
Thank you.
Great. Thank you. Thanks for having me.
Thank you.
Thank you.
Coming all this way for us.
Appreciate it. Thank you. Thanks.
And thank you for your work.
Thank you.
Hi, Jeff. How are you?
Good morning.
feel like we just saw you.
You did actually last week. So thank you again for having me back to talk about the contract pharmacy impact on FQHCs. It is enormous impact on FQHCs and us in particular. Kristen, can I share my screen now, or somebody is that?
Oh,
try again.
Kristen just stepped away for a moment.
Oh, okay.
Your slides are
Your-
on our page.
Your slides
Sharing
are
is
on our
not turned
page.
on.
What is?
Sharing is not turned on. So I
They're-
can't share.
So they're on our page right now. So if you want to just go ahead, we are all looking at them.
Oh, okay.
So if you want to start, and then when Kristen comes back, we'll have her.
Perfect. That's
Allow
fine.
you to
If wanna- Yep, if you all have it in front of you, then that's terrific. So one of the things so again, Jeff McKee, the CEO of Community Health Centers serving Chittenden County and Southern Grand Isle County. And I am truly glad to be here to talk about this issue. The first slide that I had prepared was the trend lines for our operating loss or gain or loss for the last since 2019. And you'll see that if you look at that, that's the lower of the two lines. The other line there is our net revenue from contract pharmacies related to 340B. And what you'll see there's a lot of information in that graph to be gleaned, and most importantly among them is that without 340B contract pharmacy revenue, we have a loss going back every year to 2019 and prior. That's just as far back as I could pull the data. It is vital to the sustaining of FQHCs across the state. You'll also see that the decline in the 340B revenue for FQHCs, or at least CHC, very much tracks almost in alignment with the decline in the net operating loss for the organization. Now, that's not causal, but it's contributory for sure, right? And so across that same period, our peak 340B was in 2022, and to where we are projected in 2025, these are our fiscal years. That was a $1.8 million decrease in 340B funding for the federally or for community health centers here in Chittenden County. So that was just wanted to highlight that. And I kind of reorganized the rest of the slides as just to address some of the testimony that had come over the last couple of days that you received, and to try to clarify things from an FQHC perspective, which I think is a little bit more simple to think about than maybe the hospitals who have multiple different aspects of what they do with the 340B program. But the critical question is, does the 340B program help increase access to medicines? Absolutely. It increases access for the federally qualified health centers to see providers. Most of us don't have in our budgets a place where the 340B revenue is tied to specific programs. It goes into the overall operating budget for the FQHCs and helps us do things in the community that we wouldn't be able to do otherwise. Okay, I can share now. Okay. Okay. And so, yeah, no care is no medicine, essentially. And that's the way the program is designed to work. And does 340B drive utilization? No. I got to tell you, in our FQHC, our providers do not have time or to even contemplate 340B pricing when they're trying to see patients in front of them. There is no connection between utilization and 340B costs coming out of the FQHCs generally, and certainly not here at the community health centers. But what is driving a lot of those costs is almost all of our patients come in almost asking for specific medications because of what they see on TV and the marketing that is ubiquitous related to certain medications, particularly really high priced medications. the 340B program is responsible for a drastic increase in contract pharmacies. We were a part of that. We literally went to every pharmacy in Chittenden County, and I wish there was pharmacies in Grand Isle County, but went to everyone in Chittenden County and asked if they wanted to be part of the program. And if they said yes, we signed them up. Because that increases more access and full utilization of the program as we believe it was designed. Does it squeeze out smaller retail pharmacies? No. But we literally went to everybody and said, do you want to join? Some of them chose not to, and that was fine, and they had their own reasons for that. But it's really the manufacturer restrictions that limit access to specific pharmacies and becomes a huge health equity issue. Because some of the restrictions, for example, may say that we need to choose one pharmacy by manufacturer for that manufacturer's as the contract pharmacy for that manufacturer's medications. And so for our large footprint, we would have to choose one pharmacy, which is not just Walgreens. It may be Walgreens on Shelburne Avenue in South Burlington, not and so the Walgreens, the 5 other Walgreens in Chittenden County would not be eligible for the 340B pricing program. So it does create these kind of disparities that leave out other folks, but that is exclusively created by the manufacturers, that kind of dynamic. That was not part of the original design of the program, is an unnecessary kind of component. Big question everybody has, where do the 340B savings go? They go to 3 places as far as our records show, and the reports that we get. They come to us, the covered entities, the FQHCs, the hospitals. The contract pharmacies get a dispensing fee, a little bit of variability in that, but they all get a dispensing fee. And then there's the admin fees, which go to third-party administrators. You've heard people talk about the TPAs and so forth, and that amount varies depending on the TPA. And sometimes we have a choice of the TPA we use, and sometimes we don't. But they're a necessary part of that. I don't have any answers about how to limit that or get that down. But even with those admin fees, for us, again, it's a $1.8 million kind of loss of revenue that we're experiencing here at the community health centers.
Is that a TPA to just administer the 340B?
Yeah,
For FQHCs?
Yeah, it's doing all of that data. The program is ridiculously complicated to match up all of the data coming out of the FQHCs with or any covered entity about to whom the prescription was written and whether they were a patient, and to match that up with pharmacy data and the benefits data. That's what the TPAs do. And we have folks here in our office, almost a full-time person that just manages our data going out and then the data coming back from them and reconciling that. It's an enormous amount of work, and the TPAs do most of that.
Do all the FQHCs use the same TPA? Do they all have the same program? Or do
No.
each of you have your own, like community health centers
Yeah, so sometimes we have a choice, and where we have a choice, there's variability across the state. Some pharmacies say you need to use ours. They have a specific TPA they work with. Not all pharmacies, retail pharmacies work with all TPAs. So, yeah.
Daisy, I think Daisy has a question.
Jeff, to your second point around what covered entities do with the savings, is there anything that assures us that these are some of the things that they will do with the savings, or is this just your observation?
Yeah, so, there's we've never been required to say this is what we're doing with the savings. With FQHCs, we have such operational losses and we do so much unfunded work anyway. It's hard to kind of, we could come up with something, but it would be hard to kind of, in the moment, kind of target these specific dollars. They do go into the general operating of most FQHCs and cover those things that I've been talking about for a few years now, that we're unfunded for and that create the deficits.
I don't doubt that with FQHCs. I'm just looking at some of the other entities that, you know.
But there's nothing in the regulations that make us tie that into anything in particular.
Thank you.
But you know, in our case, it's homeless healthcare. I wish that were funded appropriately. It's just not. We do a huge amount of that. Many other FQHCs, including us, rural outreach is another issue. And when you think about some of the clinics that are closing and the decisions that we've made at CHC, for example, I'm sitting here in Essex, which is our administrative home for the organization. If we didn't have the 340B money, or if it were at the level it is now, and we had that same trend line I showed you earlier, we would not have said yes to this building that I'm sitting in here now in Essex. We would not be here in Essex. We wouldn't be in Grand Isle. Like, those are programs whose margin is so thin that it doesn't make sense to go there. It's really hard to say we're going to open a new practice and know we're going to take a loss unless you have some money coming in to help cover those deficits. And for us, that's 340B. It has been for almost 15 years. So. And interpretive sort of care and just, as I mentioned, all the operational deficits. And then the last thing, just to summarize, and then I'll answer any other questions folks have. Obviously very supportive of H266, and thank you for bringing it forward and trying to keep this money in Vermont and not have it go back to pharmaceutical companies. It's vital to the services we provide, and it's absolutely essential to stabilizing the crumbling FQHC foundation. It really is. I can't say that more strongly enough. In addition to the other things we've talked to you about already with the Medicaid reimbursement and bridging the gap between the ACO and the HED model with some of the funding. So I'll stop sharing and see if anyone has any questions.
Any questions for Jeff? Oh, I have one. I do any FQHCs that you're aware of have their own contract pharmacy within their?
Yeah, so there's a couple of us that have, including us, in the last couple of years, opened our own pharmacy. So it's not a contract pharmacy, we own the pharmacy, but it is eligible for 340B pricing. It wouldn't fall under the H266 umbrella, so I didn't include that data here. We did that to somewhat hedge against the decline in the contract pharmacies, because that owned pharmacies are not subject to those restrictions, and the manufacturers can't cut back on that for us. Yeah. But there's 2 or 3 of us that have our own pharmacies, 3 that I'm aware of, and then 5 of us actually collectively own a pharmacy, a mail order pharmacy as well.
Okay. And you do, I'm assuming, rate negotiations with the payers? Or how do they pay you?
Yeah, no, we don't. With the payers, it's no, there's no negotiation. I'd have to go back and see how all those prices get set, but we're handed the prices. We don't have any negotiating price on that. The 340B price is set, yeah, we don't pay a TPA for the work that we do ourselves, which is nice. So we don't have to pay that administrative fee.
Okay. Any other questions? All right. Well, great. Thank you.
All right. Thank you all so much.
Thank you. Thank you.
Okay, bye-bye.
And we're going to hear from Jessica Barquist before we take a break.
Hello, good morning. Jessica Barquist, Planned Parenthood of Northern New England, and I will be brief. Ours is probably the least complicated, as all of the other entities you've heard talk about today, and I know I'm standing between you and a break. So we support H266 as introduced. This bill would provide us that support as a safety net provider by preserving this program, and it will protect access and services to our patients. So PP&E participates in the 340B program as a covered entity, and we purchase family planning and family planning related drugs at that lower cost than non-340B purchasers could access. And we operate our own pharmacy. And so we essentially just pass these cost savings directly on to our patients. So a good example is that we can purchase the Lolita IUD at about $100 and the manufacturer list price is $981. And so we are able to provide that device to patients on our sliding fee scale without incurring significant losses. So really without this program as it's intended and as it's running now, our expenses related to our contraceptive supplies would be more than double, and we would not be able to provide that low and no cost contraceptive services to our patients in the same way. So we are incredibly supportive and thank you for this work.
Any questions? Yeah, Pepper.
And correct me if I'm wrong. You mentioned, at least I got the idea or the understanding that you're charging individuals for contraceptive services.
Services are, most of our patients receive services on a sliding scale fee, which could be no cost up to, an average rate for those services.
I'm sorry, are you referring to uninsured patients?
Yeah, I mean, some of our patients do have commercial insurances and we would bill those insurances as appropriate for those services.
And my understanding that there was a law passed that stated that people that are in that age group where they could become pregnant, they don't pay for them. They're free.
I will double check on that. I think certainly some services are free, but I don't think all family planning services are free.
Well, I don't know family planning services. What I'm talking about is an individual, and I think you used the term IUD. Why isn't that free? I thought you're supposed to provide one kind. Free.
Let me double check on that. There are certain programs that provide free. Certainly, patients who are in like the extended Medicaid program, the Access Plan, get free contraceptive services, and there are other plans, but I don't know that that's necessarily true for every patient that we see. But I will confirm that for you.
I would appreciate it if you would, because
Absolutely.
my understanding was that condoms and it's free,
We certainly provide condoms free for anyone who needs them.
but it goes beyond that.
Yes, I understand what you're asking, and I will get back to you.
And if that's not happening, I'd like to know
Absolutely.
Great, so Jessica will get back to us on that. Thank you very much. I think we're gonna break our next. Wow, we really caught up. I'm sorry, I'm like,
Started early.
well, no, but we were running behind for a while. So we're back here at 11, and I think we will have to be back at 11 because I'm not sure Legislative Council will be able to be with us until that time.
that. Okay.